have my slides though. Right, okay. So we've had lots of interactions through the day and there's been lots of questions, calcium score, when calcium, when CAG, when CTA, when stress. So I just thought this will now sort of sum it all up. So recent publications and evidence on cardiac CT. I have no relevant disclosures. Publications always follow some sort of a need, a demand, a requirement. And the first publication I picked up is the May 2023 Lancet paper that's actually showing that the burgeoning cardiovascular disease epidemic in Indians' perspective on contextual factors and potential solutions. So it's not directly CTA related, but it just shows what is the local demand that is going to come up. India is facing this cardiovascular epidemic with higher relative risk burden, earlier age of onset, higher case fatality and higher premature deaths. And the cause is a very complex interplay of population biological factors where you have 6 transitions that are responsible, you have prenatal, postnatal and inherent biological differences. What's really alarming is that we have Indian statistics which is showing that Indians present with CVD a decade earlier. Age standardized death rate is much higher in Indians. The DALY rate is 1.3 times the global rate. There's a significantly higher rate of Mason mortality. There's lack of hypertension, diabetes control. We are also up against an aging population where the percentage of population over 60 is expected to rise to 19% by 2050. And while the total population will grow at 56%, this population will grow at 326%. So now you know as cardiac imaging where we are up against. There's also all this rapid urbanization and industrialization that has increased all the risk factors. And then there's this whole nutritional transition that has happened in our country where the intake of healthy foods has decreased. We have now high energy foods, much more affordable foods which are dense in energy and processed. And we also have a decline in per capita calorie consumption, but unfortunately there is more in the protein and an increase in the fat. So how can CTA and we as imagers really help? One of the companion publications is from UK in Jan 2023. Which has looked at determining the impact of temporal trends in imaging related outcomes for CAD. And the investigations they picked up was from 2012 to 2018 through their database. And what was shown was that there is an apparent trend between growth of CCTA and reduction in invasive CAG across regions. And this was linked to hospital admissions and mortality registries. There's a rising trend in growth of CCTA, and this was associated with the reduction in cardiovascular mortality, IHD deaths and all-cause mortality. So definitely CCTA is helping. And what was interesting is that the cost of healthcare was not increasing despite the increased number and utilization of CT. So the conclusion was that the greater regional increase in CCT is associated with fewer hospitalizations for MI and a more rapid decline in CAD mortality. So now the question is back to our requirement. Can Make in India simulate this trend? Is CCTA the answer to our epidemic? And we know in medicine, between demand and supply lies that justification and validation. We need to justify anything we want to do. And that's where the guidelines come in. And publications and evidence are nothing but, effectively all this is surpassed by guidelines. And guidelines are this set of rules that are created by this official organization that tells you what to do and how to do something. And the inclusion of CCTA today as a class 1 indication in the current guidelines is really a huge win for CCTA. So this largest publication and the most relevant for us is the 2021 chest pain guideline, which is the first symptom-based guideline that has come up. Chest pain, we know, is the single largest indication for CCTA, and it is the most appropriate evidence and publication for CTA in recent times for chest pain guidelines. And this is the result of a huge substantive evidence which is vetted by a conglomerate of multi-societal global experts. So basically, everybody who's in the system is in this paper. And you have CAD, we know, is very diverse in its symptomatology. And what now they're saying is you need to describe it as cardiac, possibly cardiac or non-cardiac. And the 2021 guidelines have transitioned from the traditional CAD definition of obstructive stenosis to a new definition where we're talking about non-obstructive atherosclerotic plaque and obstructive CAD. So this is where we've defined it, where originally, I can't move the pointer. Oh, you're one behind. Okay, strangely you're not seeing this slide. But effectively what has happened is that previously the threshold was at a level where we were looking at no CAD, where even if you had mild, moderate, any level of the cataracts, till you came to 70% for the other arteries and 50% for the left vein. That's when you said it was a CAD. But now even a minimal plaque comes to CAD. क्या क्या? नहीं आई नहीं शायद दिखी नहीं. Anyway, so the approach is that you need a patient-centric shared decision-making today. You need to choose the right pathway. You need to have a pre-test probability. You need to check the patient's age, sex, exercise capability, prior tests, and then you need to have anatomic versus function testing. So all this needs to be very well evaluated, and we as imagers need to understand it. So before testing, we need to have the pre-test probability. We need to have the clinical decision pathway, which is based on your history, physical examination, ECG, X-ray, biomarkers, and the prior testing. And then the risk stratification is done for MACE based on the chest pain and the cardiac testing. So this guides the further testing and management. So if the patient has acute chest pain and if it is asymptomatic, you may need no testing. But if it's low risk, you may want to defer testing, or you might want to do just the calcium score. And then intermediate needs anatomic and functional testing, whereas high risk we know goes to the invasive CAG. The scenarios that have been described in this paper are, is it acute or stable chest pain? Is it no known or known CAD? And is with or without prior testing? These are the three things that you need to look at when we're looking at anything. And then the role of CCT in different scenarios. So in acute chest pain, based on the CDP risk stratification, there's no risk, then again no further testing. High risk goes to CAG, intermediate goes to further testing. And here then you have to describe acute chest pain with intermediate, no known CAD and no prior testing. CCTA is a class 1 indication. And this is for exclusion of atherosclerotic plaque and obstructive coronary artery disease. Post CCTA, then that will guide your management and aid your diagnosis. If the obstructive CAD is seen or there is an inconclusive category, then you go to FFRCT, which like we described, is it really relevant? Well, it's today a class 2A indication. Going to the other subgroup, which is acute chest pain with intermediate risk, no known coronary artery disease, but prior testing exists. Then you have to look at the prior test, and the warranty period for the prior negative test in CAG and CCTA is only 2 years now, and for stress testing it's 1 year. Okay, this has been changed from that 5-7 year that we were thinking about. So if you have a prior inconclusive or abnormal stress test less than 1 year, you go to the CCTA, which now has become a class 2A indication. If you have an intermediate risk patient with known coronary artery disease, how do you say known coronary artery disease? Means on some prior test, the patient either had obstructive CAD, ischemia, non-obstructive CAD, that means even if he had a plaque, or he had a calcium on a calcium score or on a CT chest, in whichever format he had any prior test, you have to take it as prior testing positive. Then you have two options, either defer the patient and give him medical treatment, or you need to have further testing guided by the prior results. And if the prior results show non-obstructive CCTA for plaque progression and obstructive coronary artery disease, then you're looking at CCTA as a 2A indicator. For stable chest pain, again we're going to look at the pre-test probability based on age, sex, symptoms, and here you may want to add calcium score, because the calcium score addition definitely increases the pre-test probability, and that's why we said is it 0 or anything above 0. The CDC, or the clinical decision pathway for stable chest pain and no known coronary artery diseases like this, and then you've got the low risk patients, again no further testing. Selected patients can have calcium score or an exercise ECG as a class 2A to improve your risk stratification. And then we're looking at intermediate or high risk patients with further testing, where CCTA becomes both class 1. So effectively what's happened is that they have made all these, and they've also included INOCA, which is the ischemia and no obstructive coronary artery disease. And then you've got clear algorithms to how to function with these. So which test should you choose? The instances where CCT and stress test have the same class of indications, are both 1A or 2A, then how do you choose which test is really needed? Should I do the CCT or should I do stress testing? There what has been said is that depends on the pre-test probability. If it is low, then no test needs to be done. The only option is calcium score. If it is intermediate to high, if it is a younger patient under 65, what you're looking for is obstructive CAD, then favor CCTA. But if it's an older patient over 65, and what you're looking for is ischemia, then you're looking at stress test. So these are the, this is what the paper now describes, where if it's a patient under 65 with the presence of, do you want to rule out obstructive coronary artery disease with prior functional testing being inconclusive, then you need to look at it. But what the test has also said is that the site expertise and availability of CCT is really important, and that's something we need to be very careful about. So the ideal patient for the CCTA in the 2021 chest pain guideline is a younger patient under 65, intermediate pretest probability, prior functional test for CAD being inconclusive, high quality imaging and interpretation with the aim to evaluate CAD, detect plaque, extent and estimate ischemia, rapid diagnosis, safe discharge is possible after the CCTA, and you want to make sure that there are absence of contraindications. It has also given a very clear understanding of the capabilities of different modalities and the contraindications for each, which need to be clearly understood. For any imaging modality to be number one, we need to understand where does competition stand. And that's when I picked up this other publication from 2023 out of Nature, which evaluates the appropriateness of not just non-invasive but also invasive modalities in comparison to CT. The target was looking at three major questions: which is the best imaging for direct confirmation of CAD, which imaging helps identify the best treatment strategy, and how imaging improves procedural planning. And this paper summarizes the evaluation of various features that we're going to see when we're looking at the cross-section of a coronary artery. The clinical characteristics and appropriateness of imaging modalities has been looked at with median ratings of 31 experts with 29 clinical questions, and we were looking at various modalities where comparison has been made of imaging tools for coronary stenosis and atherosclerosis based on temporal and spatial resolution, penetration, risk of ionizing radiation, contrast, tracer and non-contrast studies. So they've looked at CT, MR, PET, SPECT, ICA, IVUS and OCT. So all these have been clearly evaluated based on susceptibility to artifacts, small vessel assessment, user dependency, need for ECG testing and sedation. So they've gone through a very, very detailed analysis of all these, and what they found with CT was that it was excellent to look at intimal thickening, high-risk plaques, body calcification, all the high-risk features, together with the pericoronary adipose tissue inflammation. When you're looking at MRI, which Dr. Priya talked about in the morning, you're looking at coronary vessel wall, you're looking at coronary MR angiography with plaques, you're also looking at gadolinium enhanced distinct signal enhancement in areas of stenosis. So areas where you have experts who are looking at MR, you can look at plaques. When you're looking at PET, you're looking for active microcalcification and inflammatory cell infiltrate. With IVUS, I won't go into the IVUS and the OCT, you're again looking at various vulnerable plaque features and their penetration. So CT becomes the method of choice to rule out obstruction, enable quantitative assessment of coronary plaque, dimensions, composition, location and risk of future MACE. MRI facilitates visualization of this plaque where possible. PET is used for inflammation, SPECT has a limited role. Invasive CAG of course is very good, it's a reference standard for stenosis but does not characterize coronary plaques. IVUS and OCT allow identification of plaques at high risk of rupture, but OCT has a high temporal and spatial resolution but a low penetration than IVUS, so we need to understand what's good where. The next paper I have is implications of CT reconstruction algorithm on coronary atheroma quantification. We've been talking about whether we should be quantifying our atherosclerosis. So this evaluates different CCTA reconstruction approaches in assessing vessel characteristics. What was interesting is this paper picked up only 15 participants with chronic coronary syndrome, and they took out 7,241 matched cross sections over 50 vessels that were included, and 12 CCTA datasets were used. They used reconstruction algorithms of two different kernels. So remember, I was talking about soft and hard kernel. They looked at two slice thicknesses, 0.75 and 0.5, and three different strengths of advanced iterative reconstruction algorithms. So they looked at all these three, and then they looked at all this. And see how they did the software-based co-registration of IVUS with CCTA images. And the longitudinal view of the IVUS pullback and the CCTA were put into corresponding areas, and cross-sections were taken. And the effect of the slice thickness and the IR strengths on plaque visualization CCTA became evident. And what was found was that the overall CCTA underestimates percentage atheroma volume and total atheroma volume, and is capable to detect only 2 out of 3 lesions detected on IVUS. So remember, we are inferior to obviously IVUS. Then subtle changes in the reconstruction algorithm had a profound impact on lesion characterization and atheroma volume. So even if you made a little change, it made a tremendous change to your atheroma volume. So the results were that at a segment level, there was good agreement between CCT and IVUS for atheroma volume with approach of 0.55, which is 0.5 is your slice thickness, and the highest level of admire iterative reconstruction being the best. At lesion level, there was no difference between CCT and reconstructions. However, there was an approach that was superior. And then you had the conclusion that CCTA reconstructions with thinner slices, with a smooth kernel and the highest strength of iterative reconstruction enabled more accurate quantification of lumen and plaque at a segment and lesion level. Okay, so basically you've got to realize that how you're going to play the game and how you're going to use the CT is very, very relevant. The next publication I picked up was this large nationwide registry with a 5-year outcome, which Pavan was talking about this morning. Are we going to have a registry that's going to tell us in the future of what's going to happen with us? So after CCTA, they did CCTA in 110,000 patients in Denmark. And this is a long-term cardiovascular risk of patients examined with CCTA to rule out CAD compared to population controls. So this, what they did was that they evaluated 5-year outcomes of MI or revascularization and all-cause mortality in 3 distinct groups. In these 110,000 patients, 48,000 were not prescribed with preventive pharmacotherapy, like we've been talking, should they be put on statins. 42,000 we prescribed preventive pharmacotherapy, and 20,000 they said they diagnosed with MI or they were revascularized within 180 days of the CCTA. And each patient had a matched control. The outcomes were based not on disease severity, but on the management post-CCTA. So we were not looking at disease severity, now we were looking at what is the outcome. And preventive therapy or not, and revascularization/MI compared to age and gender matched population controls. And the conclusion was 180 days post-CCTA, the 5-year MI or revascularization risk was very low for the CCTA examined patients without ischemic events, and was significantly elevated in the CCTA examined patients with MI or revascularization events. The last of my papers is out of the JCCT, since this is an SCCT collaborative effort with IACI. So this is the cherry on the cake publication of 2022 practice guidelines of CCTA in acute chest pain in the ED. And this is an expert consensus of SCCT endorsed by ACR and NASCA. And patient-centric algorithms for acute chest pain in ED have been defined with the role of CCTA with cataracts. We've just gone through this whole segment of cataracts, and that's why I sort of decided to do my presentation after. So the risk stratification tools in suspected ACS do exist, but what is recommended for the chest pain pathway is that patients with no known coronary artery disease, if you have a low to intermediate risk, then of course CTA is the most effective to rule out ACS. You may want to take it to the level of a triple rule out in case you're suspecting something like PE or an acute aortic syndrome. If it's a high-risk patient, patient goes to a coronary CTA, which is an alternative to functional test or invasive CAG. But if it's a very low-risk patient, then the patient may benefit in case you want to look at either excluding CAD or to provide risk stratification, then you might do calcium score or coronary CTA. Patients with CAD, post-revascularization CTA is usually appropriate in patients with stents over 3 millimeters and to look at prior grafts, which we've been looking at through the cataract scores. So guidelines for shared decision making in patient prep, we must know when is the cardiac CT, is it right for me? The patients need to be screened, and we need to be very well aware of the contraindications, the heart rate lowering medications, whether nitroglycerin needs to be given or not. We need to understand all the protocols and hopefully follow the SCCT guidelines for performing the CTA, and the lowest achievable radiation dose needs to be done. The strategies to improve quality in scenarios when CCTA may be difficult or non-diagnostic is like high heart rate or AF, irregular rhythms, high coronary calcium, stents, morbid obesity, difficult, can't put their hands above their head, tachypneas, IV access being difficult. So we need to understand all these, which we come across in our day-to-day practice. And we also know in scenarios when risk associated with CCTA may not outweigh the benefit, we need to be looking at that, particularly in the pediatric and the young adults, pregnancy, renal insufficiency, contrast allergy, drug reactions, low BP, and other contraindications. So today's
2 minutes,
CCTA is the center stage. The last slide. So today's CCTA is the center stage for CAD evaluation. The potential for future research is that we have unanswered and newly emerging questions, because we now can see a lot on our CCTA. We can in fact now with our new photon counting CTs probably be able to see literally like they were talking about the colonoscopy. So what to do with non-obstructive coronary artery disease? Plaques, quantification, vulnerability assessment, which is exactly what we've been discussing all this while. How do I treat the patient based on the CCTA finding? Enable CT-guided strategies of care. When to follow up the patient, repeat CT, because lots of patients come and say, what kind of a warranty do I have, 2 years, 5 years, 1 year, whatever. Secondary preventive guidelines and the impact of CT on clinical outcomes. Thank you so much for your patient listening.
So questions, thanks Mona, great lecture. And questions. Tarun?
thanks to Mona for excellent presentation. You highlighted the first paper was probably the most important paper, looking at the epidemiology of heart disease in India. And then the second study from UK on which claims that cardiac CT possibly reduced the mortality. But I don't think it is causative, as you know, that there was simply a trend of reduction of cardiac mortality during those 5 years when cardiac CT use increased while use of other techniques reduced. So, what's that? So I'm not sure that cardiac CT as such would be increasing practice of cardiac CT in India would reduce the burden of heart disease or outcome from heart disease. But what probably is important if we do use cardiac CT, which I'm sure is going to grow exponentially in India over the next 10 years, I think is the education of the referring clinicians, what the plaque means in our practice and what preventive therapies can they institute. That's probably where that's what's going to drive the change in mortality. But most important is our lifestyle in India is, as we know, is not very good. And it's getting worse day by day, isn't it?
But
So totally, I agree, Tarun, absolutely. All I can say is that I've put what's on the paper in front of you. I'm sure everybody has their own takes on it. Everybody will go home with a different answer, or we have papers which give data. The data is analyzed differently by different authors, and all of us make our own assessments too. So yeah, sure, but and lifestyle in India is going bad. We need to do something. We need to start scanning patients early, and I think we can only help them that way. And for sure, I believe that atherosclerosis is a disease. We need to catch it early rather than wait for the ischemia or the stenosis of the level where they become, they get to a higher level where they come back to chest pain.
yeah, but that was an opinion piece, they just put together stuff. Don't do that. It's very distracting. Light mat laga. So the only study that has categorically shown an increased risk of an increased South Asian risk is the Masala study, which was out of Chicago, but it was multi-center. And a little bit from the UK, where they've shown South Asians in the UK to be at increased risk compared to non-Asians. But in India, we don't have anything. What we do have is, forget about this, we have a high burden of high blood pressure and we have a high burden of diabetes, which together are far, far more important than looking for coronary artery disease. So to reduce burden of cardiovascular disease, what we really, really need to do is just measure blood pressure and measure blood sugar. With remembering that India does not have a single mandated population screening test. I don't know if you all are aware. We talk of screening. In the US, for example, or let's talk of UK, Tarun's there, you can tell me if I'm right or wrong. The NHS will mandate that X number of tests have to be done, your GP will make you do them, and they're done free. Or in the US, the insurer will cover a certain number of screening tests for free, and then these get done. India doesn't have a single mandated screening test for the country. Some states may have implemented blood sugar, blood pressure, etc. So we talk about all this. But cardiovascular risk reduction in India is a very low-hanging fruit situation where first we just need to, at a population level, measure blood pressure and blood sugar. And if you can do that and reduce the incidence, prevalence and treat hypertension and diabetes, you've pretty much achieved a huge thing. Uske baad plaque dekhenge, that's later, yeah.
That's exactly what I said. The
Exactly.
control of hypertension and diabetes is abysmal, and the greater insulin resistance and the higher insulin levels and prevalence of diabetes is really pathetic in our country.
Yeah.
And the rapid urbanization, you've got every single risk factor that's growing, the hypertension, diabetes,
So
obesity.
that second statement is wrong. I think the people who wrote this.
I have not written this. This is
No, so I'm telling you, the authors who wrote it are wrong. Our population is peaking in 3 years. We've hit 1.42 billion. At the most, we're hitting 1.48 or 1.5, and then the population is dropping. Except for 4 states in India, Uttar Pradesh, Bihar, Madhya Pradesh and Rajasthan, every state has started degrowing. Only these 4 are growing. So we're going to not grow by 56%, we're going to grow by about 2% or 1%. But the aging population is right. So that is, right now it's 7% of people in India are above 70 years of age. And then that's going to keep increasing as the population ages. The other statement that these authors have made, which was that the incidence of cardiovascular disease is in younger people, is the same thing. If there are only 7% of people above the age of 70 in India, then obviously CVD occurs in younger people. No, I mean, the spread of population is such that you have such 50% of India's population is at the age of 29. So obviously it's going to be a lower age. So that doesn't work here.
The kind of risk factors that the youngsters are seeing now, the high stress and the kind of...
That's fine.
It's really a different level again. So I think there's
that's
definitely... And like
worldwide.
you said, it's a low-hanging fruit, an easy fruit, it's an easy piece to handle. And I think we as cardiac imagers really need to attack it, need to, make at least the stakeholders aware of it, if not the population, so that we have more and more people who are not insecure about the lack of CAGs, but in fact look at population health in one way.
Quick questions, yeah, Tarun.
Can I ask another question? So regarding the same topic, if in India one was to recommend an imaging test for plaque burden, do you think that calcium scoring will be a better test because it's cheap, easy to do, cheap, the quantification is easier, radiation dose is lower than that of CTCA still. So with all those factors, in an asymptomatic person...
See, the point is, what is the age at which you're looking for it? Sorry, you want to say something?
Yeah. No, irrespective of patient's age, but calcium scoring is good till from age, even 30, from 30, so if you have atherosclerosis developing, I've seen patients as young as 20 years having calcified plaques in the coronary arteries, if they are going to have significant stenosis. So I think you can start from 30 years in the Indian population. In West, it is 40 years. In India, it can be 25 or 30 years, 30 years of age, and then go up to maybe 70, 75, whatever. But in terms of comparing to CTCA, would calcium score, if the government is going to recommend a test, I'm saying.
Government will not pay for anything. So
no, that's what I'm saying. If it's going to recommend...
I think that if the government is to give some sort of a blanket test, then the only test that can be done is a calcium score, because that's the only thing that's like a straight line layout, no contrast, no IV, no contraindication, nothing else other than the radiation, which is low involved. That is the only thing that can be done. But I don't think that's really relevant if it's in the age group under 35. I don't think it would really catch a lot, because if our intention is to pick up the patients who are early, then we need to do this whole CCTA. But then I think we need to also look at risk profiling, what is the patient's family history, cholesterolemia, all that. Because I think there's a lot of people who are also on statins just random. And the moment they are on statins, you find their calcium sort of soaring. We're probably the only country where people come in with calcium scores of 4,000, 5,000, any number you come across, especially these young corporates who started eating statins and high-dose statins when they came out at the age of 35. I mean, these were all the bankers and the lawyers who were on very high statin doses, and they've been on these doses for almost 25 years now, ever since statins came into vogue. They went to the US and everybody put them on very high doses.
My other take on this is that when we talk of bankers, lawyers, high-stressed job employees, all these people who are our patients, they constitute 5% of the population. Let's not forget that most of us don't even deal with the other 80-85% of the population. And I think whatever solution we need has to be a solution, if at all it's to be implemented on a mass scale, a very low cost, cheap, easily available solution. If at all you need an atherosclerosis test, it would, apart from just doing your LDL levels and blood pressure, diabetes, it would be a carotid intima-medial test. A CIMT with ultrasound would show, then I take it back. Yeah, absolutely.
It has only prognostic power for strokes, not for heart attacks and not for dying from heart attack.
I have one comment, and I'm not sure whether I'm right or wrong, so somebody can correct me. So when we're looking at the acute chest pain guidelines, they came out in, I think, April 21 or Feb 21. The ischemia trial was published in August 20 or September 20, and I don't know if the ischemia trial results were incorporated in that entire guideline set, because ischemia trial has changed everything. And if it has changed everything, then every guideline that did not incorporate the results of the ischemia trial clearly then, and then there's this other trial that came out in the UK of stents versus cabbage, but that also looked, sorry? Revive trial. So these have changed practice completely in most Western countries to an extent, not in India because we are lagging 15 years behind.
Ischemia trial was an easy trial for all cardiologists. Do what you like, kind of a thing.
It says don't do what you like, don't do anything.
But they said if you think and all the way to I think it was quite a free-for-all story.
No, the ischemia trial, according to me, is very simple. Chronic stable disease, don't touch. That's it. Don't touch. Don't revascularize. Anyway, if there are no more questions, thank you so much, Mona. This was a great one. Thank you. And Ankita, do we have? Ashita. Sorry, I'm so sorry. I think I'm just coffee drained.
I love Ankita too.
So, alright, so this brings us to the end of the SCCT session, and I'd like to give a memento to Dr. Mona Bhatia. I request Dr. Bhavin to give a memento to Dr. Mona Bhatia. Thank you for the wonderful presentation. It was a great summary of all the articles. Thank you so much. Thanks everyone for attending today. I hope you guys will go and look at the quiz and answer the quiz. It's going to be put up in the next few hours so that you're able to answer the quiz. So let me tell you how this works for those who haven't understood the app and how to answer the quiz. So the quiz is played on one screen, which is towards the counter. And you need to open the quiz, Dr. Ravi Patina quiz, the icon on the app, and that will give you the questions, and you can just select the answer. It's a multiple choice question. So we've kind of included this app in our entire IACI program. You can look at everything that's happening in the conference on the app, and delegates can also interact with faculties that they're interested in on the app. There's one caveat to that. We just realized that the name of the delegate does not come to the faculty if you do not write your name. So when you're sending messages, or if you want to get in touch with any of us, any faculty, any delegate, you want to get in touch with each other, please feel free to use the app and just mention your name at the end of it. And please go and answer the quiz. The quiz is not just a competition, but it's a very good learning opportunity. This quiz will be played only for today. We have another quiz tomorrow, which is based on cardiovascular MRI. Thank you very much, one and all.